So what is the best approach to diagnose prostate cancer? This is the trillion-dollar question I ask always many of the experts that come on, and I'm always interested in each individual answer because they're not always the same. Do you use genetic biomarkers? Do you use urine tests? And once you're diagnosed, who is a good a candidate for active surveillance? How far can we go with this? A person with a Gleason 7, regardless if it's 4 plus 3 or 3 plus 4? And lastly, the music trial. The music trial, so good. Today's conversation is with Dr. Todd Morgan, who is a urological surgeon and chief of urologic oncology at Michigan Medicine. Dr. Morgan is originally from Seattle and completed his undergraduate degree and medical training at Harvard University. He returned to the Northwest in 2003 for his urological residency at the University of Washington before then moving to Nashville and did his fellowship at Vanderbilt University. In addition to being a clinician and surgeon, Dr. Morgan is a translational surgeon scientist. His research involves development of blood vessel tests that can guide precision-based treatments for prostate cancer in real time. Dr. Morgan is dedicated to caring for patients with genital urinary cancers. His urologic oncology practice includes caring for patients with prostate, bladder, kidney, and penile cancers. And it's involved in laparoscopic and advanced robotic surgical approaches. Today's conversation with Dr. Morgan was amazing. He is one of the top thinkers in prostate cancer, very thorough, very science-based. And we discussed once again the music trial, which is a trial that collects all the data from all prostate cancer specialists and urologists and collect it in this database so they can look at their results, and they meet every so often to discuss their results and what are the things that they're aiming to figure out. What an amazing conversation with Dr. Todd Morgan from the University of Michigan. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. Welcome to the Dr. Gio podcast. I am your host, Dr. Gio, where it is my intention, my goal, my purpose to help you optimize your prostate health, testosterone, erections, and as we get older, how do we live even healthier and better? Today, my great pleasure to have Dr. Todd Morgan from the University of Michigan, Department of Urology. Todd, I can't tell you how much of a pleasure it is to have you on.
Hey, thanks, Gio. This is awesome. Really looking forward to it. I heard you give a great talk when we were at a conference in San Diego. Learned a ton. I know I'm going to learn a lot from you today.
I appreciate that. I don't know if you know the full history. I don't know if I shared it with you back in San Diego, but here I am 20 years ago at Columbia University Department of Urology. Dr. Mitch Benson was the chair. Dr. Carl Olson was the former chair. He's a legend in our field, right? But it was Dr. Aaron Katz he was running the Center for Holistic Urology. And I said, look, I'm this naturopathic guy. No, believe me, I'm not a quack. I'm science-based. No, please believe me. And all I do is urology. So we could do some great research. Anyway, long end, I start doing like a fellowship, really hone in on urology for 5 years with Aaron, did some research, published some papers, et cetera. And it was a tough time because this people didn't even pronounce it. It was too early for the times. Right now, you hear everything. You hear, fasting, and you hear, cold water plunges, and the importance of, vitamin D and perhaps sunlight therapy, and even diet and lifestyle. Big thing, a lot of research. Back then, there wasn't that much. So here I am giving talks and giving grand rounds at Columbia University. I have Dr. Carl Olson there, who is a staunch surgeon and hardcore, right? He has a reputation for being hardcore. And man, I was like, I think I had stains in the back of my pants from, just the insecurities of what I was doing and what I was trying to do. And show, look, there is science here, and kind of, no, please believe me. Fast forward all these years later, and many great urologists and professionals like yourself who said, man, that was a great talk. I didn't know that. Oh, I'm going to start applying X or Y in my practice. And it's just like, I always call my wife, because she knows from back 20 years ago. So look, this just happened. And it never seems to, it's very humbling to know that some of our colleagues are so receptive to this kind of stuff and the importance of lifestyle medicine and things like that. So
yeah, well,
anyway, all that to say, I really appreciate your words.
Well, thanks. I mean, building that kind of career where you have built it, I mean, it is unbelievable. That is not, that's not what I would expect, because Columbia does have a certain reputation.
Yeah.
But, now for when I come and sit in clinic and talk with patients, probably one of the top 3 questions is, what can I do to help myself with my prostate cancer, right? And we can talk medicine and surgery and all these things, but they want to know, what can I do? And so this is where I have to learn from you.
Absolutely. And at the AUA, right, the Urological Association meetings, I can't tell you how many of our colleagues pulled me aside for their own health. Like, Gio, what do you think of this? I don't know, botanical for this and that. And what do you do for, X, Y, or Z? And they sort of, the embracement has been just extraordinary. So again, thank you, Todd. Let's get right to it. So look, you've given several talks that I was able to see, and one of them in San Diego was this beautiful timeline of the genomic testing that you consider during the different phases of a man's process, from screening to once they're diagnosed. And I'm a big data guy. I collect a lot of information. And some of our colleagues, including, for example, Dr. Keibel, he was like, yeah, we had a mutual patient. I said, get a Decipher in his prostate. He was like, no, Gio, it's not necessary. Why? We already have this data. We already know that he has a risk of X from recurrence. I was like, oh, interesting. So it's not a gimme that everybody would order that. And so am I doing? So I'm always questioning myself and my approach with everything. So why don't you take us back and we'll go through the whole process, all the different phases of prostate cancer. I'm a man that's, I don't know, and understand my patient population. And by the way, a lot of people these days, it used to be, go to the doctor, all right, tell me what to do and I'll do it. Now you're being questioned heavily.
For sure.
Why should I do this? Is there anything else? This is almost like trust issues, right? And you have to kind of gain that trust with time.
Yeah, which isn't a bad thing. I mean, right, this like blind trust for when you walk in an office. Maybe we deserve that sometimes. Maybe we don't always deserve that. And so I think those are fair questions, and it's fair game.
Yeah, I do too. And a big part of what I do with my website and this podcast is patient empowerment, shared decision making, but based on good information and good data, not some craziness that you read on the internet.
Right.
And that's kind of the approach, particularly in the natural health world, which I think there's great information, a lot of science, but there's also, there's also a lot of, let's just say, unscientific information that people take it for face value, particularly if the person talking is a good talker. They'll sell them a bag of ice for their prostate and that's the cure or whatever, and that happens often. I'm a 58-year-old male. I have a relatively high PSA. What are the types of things that, look, I don't want a biopsy. I would try to avoid that with my whole.
Yeah, you and me and everybody. Nobody wants a biopsy.
No one wakes up in the morning, right? So I can't wait for that biopsy, right?
Yeah.
So what would you do? And I know PSA velocity and things like that, but my PSA is 3.8 and I'm 58 years old, which is a real case.
Sure.
What are the other tests that we can do to say, yep, it takes us to the next step to perhaps say, look, you need a biopsy?
Well, it's a great scenario to talk about. And it goes back to this whole issue of overdiagnosis and overtreatment. Mm-hmm. And the old model was, you've got a PSA that's elevated, we're going to do a biopsy and then see what happens. And we know that we cure some men that way, but we also find a whole lot of cancers that we don't need to treat. And we put people through biopsies that unnecessary, right? A negative biopsy ultimately is an unnecessary biopsy. And so thankfully we now have MRI and we have randomized level 1 evidence to support the use of an MRI in that scenario. So that's option A. And option B is to use one of a whole host of different biomarkers. And so there's the 4K score, there's PHI, which is the prostate health index, there's select MDX, the urine test, there's the Michigan prostate score, the My Prostate score, now MPS. Is one better than the other? Not from anything that we can tell, but it's some type of secondary testing that says, okay, you have an abnormal PSA, we've rechecked it, it's still slightly elevated or actually elevated, and we're not going to go right to a biopsy. And I would say the majority of us urologists in the US are still using the old model, which is elevated PSA to biopsy. The NCCN guidelines, the AUA guidelines, all support the use of some secondary intermediate step. And will we miss some cases of prostate cancer that ultimately need treatment? Yeah, you can't. There are no total freebies, right? But those, for the most part, will eventually be diagnosed with repeat testing. And the benefit is that far fewer men ultimately undergo a biopsy and far fewer Gleason 6 prostate cancers are ultimately diagnosed, which is a good thing because we know those are instances where we're going to use surveillance. And really the ideal state is really not finding those especially low volume Gleason 6 cancers. And so we can save biopsies and still find the vast majority of clinically significant prostate cancers.
Where are you, Todd, by the way, move a little bit to your right so that you could, yeah, perfect. Where are you? So I had Scott Egner, and as you know, he would say, let's not even call it prostate cancer, something else, Where are you? We won't hold you to it because it's an opinion, but where are you with that? Do you think that a Gleason 6 prostate cancer we should call cancer or no?
Yeah, I'm on board with Scott. I'm in the full Egner camp on this. And right. So, which means, which is to say,
one more for Egner.
Oh yeah, I mean, I've been talking about this with him for a while, and I really appreciate his leadership on this topic. I don't know if his point of view is ultimately going to win, but he has garnered the support of a lot of experts, a lot of urologists, pathologists, radiation oncologists, which is to say that there's a really good argument to give grade group 1 or Gleason 6 prostate cancer a different name. And we do a good job of counseling. Yeah, go ahead.
Not every Gleason 6 is a Gleason. I'm just playing devil's advocate because, of course, I think I agree with you. Although I do have a podcast episode from a few months back where I'm saying, and the title is something like "Why I Love Gleason 6 Prostate Cancer." So for what I do, people need to be motivated, right? Todd, exercise 6 days a week. Look, stay away from this, that, and the other food, all the good foods that you actually love to eat. Yeah, stay away from those. Make sure you get 7-8 hours of sleep. There's some nutraceutical supplements that I think are helpful. Take that in the morning and that's too much. Gleason 6 prostate cancer. The C word is there. Forget about, they don't even listen to Gleason 6. They say the C word and they're like, well, I'm ready to do anything. So oftentimes I find that to be an opportunity for them to now, do all the things that I'm asking them to do. So that's my sort of personal opinion from a non-scientific foundation. High volume Gleason 6? Should that be called? Is there a cutoff in the Gleason 6 spectrum where you would say, yes, we shouldn't call it, but no, in this scenario, I think it's going to progress. And, are we going to do biopsies every year for 8 years, 10 years? We don't want to do that. So what's your...
Yeah, so two things. One is, in terms of Gleason 6 cancer being a motivator, there's also a real downside of the stress and anxiety that the C word creates. And so, I would say, well, show me the data that the motivational piece outweighs the stress and anxiety piece with some objective measurements. And I really do worry about that. I think the amount of stress and anxiety that, men with even low risk cancer experience. I lost the thread.
So what for higher volume?
Yeah, for high volume. Yeah, thanks. So for high volume Gleason 6, and people bring this up, we have shown using music data, which is the Michigan Urological Surgery Improvement Collaborative, so data from the entire state of Michigan. It's a incredibly small minority of patients who have Gleason 6 prostate cancer who fit into that high volume category. We're talking less than 10% of those patients. And so this is the thing where we bring up this extreme scenario and use that to kind of contradict, argue against the concept. And really, it's a fraction. And so could you come up with a carve out, sure, for that 10% or fewer patients? Or you say, boy, you know what, you've got this thing that has a different name. And, you know, people have proposed many different names, but it's kind of a pretty high risk along that spectrum. And so maybe we're going to recommend prophylactic treatment. So you would think about it more like a prophylactic prostatectomy in that setting. Or we're just going to follow you exceedingly closely. And I'm not saying that we need to be doing biopsies every year for 8 years. We don't do that for active surveillance, but we're going to follow you a little closer. And we can talk about the role of genomics and all that here too.
Yeah, actually, we'll get there. We just digressed a tad because the active surveillance component of our conversation came up. You mentioned several tests. Do you order the Michigan test more often than others?
We've got the, I think a lot of it's logistics, right? So we've got the workflow down, and it's a really excellent test. There's tons of data to support it. Would I go out carrying the flag based on the present data for any one of these tests? No, I would say just our job as urologists, and maybe eventually for primary care docs to consider also, is to use some type of secondary testing. They all perform better than PSA. They all do. Mm-hmm. And we don't really have good comparative data. So just or use MRI or use some combination. And we proposed all sorts of studies, and so have others, to try to tease out which marker and how to sequence it with MRI before or after. But ultimately, if we move the needle towards more use of any of these markers, we will be improving care, undoubtedly.
Our next amazing sponsor is XY Wellness, a company I know a little bit about as co-founder and medical director of the company. XY Wellness is a company to help men renew, rebuild, and reclaim their health, their bodies, after a prostate cancer diagnosis. XY Wellness is a lifestyle company that helps provide a no-nonsense roadmap to health and wellness in men after they are diagnosed with prostate cancer. The hope with our program, and what we see with many of our members, is that men after prostate cancer tend to thrive, not only survive, through our program. To learn more about XY Wellness and its roadmap, please visit the link below in the show note. MPS is one of the ones that I least know about, and I don't even think I've seen a report on. I've seen 4K Select, I've seen XO DX, and that's because I don't think we are yet allowed to order it.
Just barely. I'll send you some papers, but yeah, there's more out now. It maybe not in New York. You guys also have different rules, but it is, so it's now commercialized. It had some hurdles. It was licensed by one company, sold it to another. And now it's in a company called LynxDX, which is a U of Michigan spinoff that actually they took a little pause or refocused for a bit on COVID testing and became a huge COVID testing lab using the same technologies. Now they've refocused back on MPS, a test called MPS 2.0. Point is, instead of the original MPS was based on TMPRSS2 and ERG, so the fusion that's present in roughly half of prostate cancers, along with PCA3. This is a post-dairy urine test. The new test adds somewhere around 20 more markers. And so it's now adding just additional layers. It's a gene expression test, looking in the urine. And it, of course, performs even better than the old test. Again, would I go out and champion one of these tests over another? No, but the data for each of these is quite good. And MPS it's going to be something that you'll be able to order. I don't know what the timing is, but over the next year or two.
So it doesn't use PSA at all in there?
PSA is also an algorithm, yes.
An algorithm. Now, and we were talking about before recording about Dr. Andrew Vickers, and I would love to have him on because I have a question that I don't think I've gotten a satisfying answer for, which is, if we say PSA is the problem, or at least that specific kallikrein, and the other kallikreins are actually probably more sensitive, like H2 or
HK2. Yep.
Why use that PSA biomarker, or why use PSA in that algorithm where now if we have and I've seen it, where if the patient has, I don't know, PSA of 20, but he has a PSA density of less than 0.10 because they have a big prostate, that number is in the algorithm, I would assume, and that will kind of muddy the waters a little bit. What will you say about that comment, and how would that apply to the MPS algorithm?
Yeah, I totally agree that PSA can be exceedingly misleading, and PSA density is ultimately maybe one of the best markers that we have, which gets back to the utility of MRI in the early detection setting. But really, the inclusion of PSA in these models is surely based on the fact that it kind of helps it a little bit. And so each of these markers ends up contributing at least enough to the model that when the numbers are run, that PSA is valuable. And then there are published data on 4K score, for example, for like the area under the curve, the accuracy roughly of the test with 1 marker, 2 marker, 3 markers, 4 markers, and combinations of markers. And actually, you get with 2 or 3 markers, you get pretty good. But then when you get all 4 markers in there, you get the best, most accurate test. And so they ultimately do contribute, at least at some level. And even PSA, for all its flaws, which are just innumerous, still contribute something.
Ted Schaefer would say, from Northwestern, he would say, look, I mean, 90% of men are working around with low PSAs. Only 10%. And if you're in a urology office, you would think that's 90% are working around with high PSA, because of course we are sent these patients and that's all we see. But, you know, globally, PSA is a pretty decent marker, biomarker, when you consider that most men are walking around with a low PSA. And if it's high, sure, we can't say it's prostate cancer, but, you know, we can see velocity, kinetics, certainly PSA density, according to Ted. You know, he's a big PSA density person, a physician. I think I am too. I think it's been undervalued, I believe, particularly in the advent of all these tests. So I in my opinion, and by the way, I'm coming out with a book called the PSA book, just kind of.
Oh, cool.
Just want to bring less anxiety to the reader on it. Here's what it is. Here's what it's not. If you're gonna have anxiety over it, then on that increase, then at least let it be over valid information as opposed to what you think it is. Because man, there is, and I start the first chapter saying there is no biomarker that causes more anxiety. Forget about high cholesterol. Cholesterol, high triglycerides. Meanwhile, you can die, right, much faster from a heart attack. But the PSA test, it's
so misunderstood. It's so misunderstood. Yeah. And I think it's awesome that you're writing this book. You've written this book. One of the key points that you just mentioned is that most men have a very low PSA. And the second piece of that is that for men with a very low PSA, their risk of dying of prostate cancer is incredibly low. And so for the guy who's 50 years old and has a PSA of 0.5, they don't need it to have the PSA tested every year. It's just going to cause more noise and anxiety. Okay. And so we can really titrate our PSA screening intensity based on just that PSA at age 45, the PSA at age 50 or 55. And if it's less than 1, then their risk of dying of prostate cancer 20 years from now, from that point, is still incredibly low. Whereas the guy with the PSA of 2 does need close screening, and the 45-year-old who's got a PSA of 3, he really needs an evaluation that maybe not every primary care sees that.
Right. Yeah, just because it's within the range of 0 to 4 doesn't mean that it's not a problem if you are of a certain age, if you're younger than a certain age. So we have those pre-diagnosis biomarkers, genetic biomarkers that you mentioned. Just order it on every patient? Does it depend? I tend to order it on every patient. But again, so I'm trying to convince the patient, or at least I'm trying to give them guidance as to whether or not they need a biopsy. So all the data kind of matters in my world because, again, they're trying to prevent one at all costs. So that MRI and so forth. Order it in your world all the time, the MPS, or does it depend?
So I would say that I and we at U of M tend to go with MRI as our first tool really the second tool, but secondary testing after PSA. And so MRI tends to be our go-to really because it gives us that target. If it's a positive MRI, then we've got a target for the biopsy. We tend to use those markers much more for, say, the persistent high PSA in the setting of a negative MRI, because that patient with a negative MRI doesn't need a biopsy, but they do need follow-up, and maybe that PSA is staying high and their PSA density is borderline or elevated, and you're thinking, well, let's get another test. So that's a really good use case for those markers. And then also the patient who's maybe undergone a biopsy, has say an abnormal MRI, the biopsy is negative, and you're thinking, I don't totally believe that. Maybe we're missing something. Those tests are really helpful. I think that, we've designed possible algorithms and are testing them hopefully in trials that are coming using the biomarker before the MRI. So you can imagine it's the elevated PSA, then you get the marker and you decide on the MRI based on the marker. There are a couple of publications on that concept. It looks really promising. We'd really like to tease it out with a formal study.
They're diagnosed. Now they're diagnosed. What is your approach to genetic testing? That's an area where I find that most urologists don't want to do or don't do, because they're just banking on the pathology report and the MRI, and that's it.
Yeah.
What is your approach?
So when we talk genetic testing, there are really two different domains. And one is the germline inheritable genetic testing, and the other is the tissue-based testing that is kind of classically called genomic testing. They're both forms of genetic testing at the end of the day. It's just one is the inherited type, tested through blood, tested through saliva. The indications for patients to undergo germline testing are more or less high-risk prostate cancer that's localized, intermediate-risk prostate cancer that's localized, any localized prostate cancer with a strong family history of prostate cancer, breast cancer, ovarian cancer, pancreatic cancer, or colon cancer, or anybody with metastatic prostate cancer. All those patients should undergo some education, pre-test education around germline testing, and then undergo the testing either ordered by the treating urologist who's given that education, or sent to a genetic counselor to provide that education, and then undergo testing if that's what the patient would like. So that's the germline testing piece. Then there's this whole issue and question of when do we use these tissue-based tests? And so these are tests like Decipher, Prolaris, Oncotype, what used to be called Oncotype, which is now called the GPS. Yep.
Yes,
Yeah. The Genomic Prostate Score, and that's after the test got sold to MDX Health. Still the same exact tests. So still the same three tests. All three of those tests are run off of biopsy samples from the diagnostic biopsy, with the purpose to help inform clinical counseling for the patient with newly diagnosed prostate cancer. Each of the three tests is really, really similar. They're all looking at RNA expression, so the amount of RNA in the tumor, not inherited cancer, nothing about their kids or family members at all. It's about that person's specific tumor and the genes in that tumor that are making it appear that cancer is more likely to grow faster and spread, or less likely, or maybe that tumor is just kind of right what we thought all along based on the Gleason score. And again, the purpose of those tests is to help us with those initial decisions, which can be quite complicated, and it can also sometimes be straightforward. Say, if a patient has Gleason 8 prostate cancer and they've got really severe urinary symptoms and they're a surgical candidate, that patient probably is going to undergo prostatectomy.
You don't need genomic testing for that.
Right. I don't need that information. And so one of the things that I really try to emphasize when we're talking about this genomic testing is we only use it when we have a decision to make that it might inform. And sometimes there's a little bit of an urge. I mean, I think we're probably all guilty of this at different times, of just saying, I would just love to have additional information. I'm really curious. Yeah. And we're all curious people, and patients really want to know about their cancer. And we're, as physicians, we're curious about their cancer too. But a test that doesn't inform a decision, that just gives us another data point to file away somewhere in the chart and never look at again, is not a really helpful test. And they're not cheap tests. And so we need to be good stewards of using the test when appropriate. But where do I use it, and where do I talk about using it? I think for the urologist, it's really for that patient with higher volume Gleason 6, with Gleason 3+4, grade group 2 cancer, where we really are on the fence. We're thinking about surveillance, we're thinking about surgery, we're thinking about radiation. Should this patient who's interested maybe in surveillance, would we really steer them that way? It's another data point that can really help us in that setting. There's also some evidence that at least the Decipher test so far, and potentially Prolaris as well, can be used to inform the use and length of androgen deprivation therapy in patients who are undergoing radiation treatment. And so there are studies looking at that, some early evidence suggesting that those types of tests may also be able to inform decisions in that context. But if that grade group 4 or grade group 5 patient, we know that if they're undergoing surgery, well, boy, we don't need another test to help us in that scenario. For that same patient who is going to undergo radiation, well, there are clinical trials that actually stratify treatment based on test result, and that patient may be a candidate. One of them is the NRG GU009 trial, where patient treatment is stratified and randomized based on Decipher score. So that's kind of how we think about it roughly.
What are your thoughts? So you know that the advent now of arterial AI to help stratify whether somebody needs hormone therapy with radiation or not. Any idea if these genomic tests are incorporated in the AI, or are those two different things?
Totally different things. Could they be incorporated? Absolutely. Will it be better?
Will they? Will they? Absolutely. Probably.
Absolutely.
I guess, right?
Probably. No? Yeah. It's completely doable. The same data sets have been analyzed. Like when we think about RTOG 9601 trial, patients who underwent salvage radiation with or without ADT, those data sets have been analyzed by both Decipher and Artera AI. Could they be combined? Yeah. Will they be? I don't know. But maybe, the answer is yes, maybe, probably.
Are you using it yet, or your institution using it, Artera AI?
It's been used on a couple patients here. We just recently got it up and running. We've done quite a bit of research with Artera AI, and so we've worked with them on that side of things. Have an AUA abstract looking at patients post, relates that RTOG 9601 is one of the cohorts looking to see how it performs for patients undergoing salvage therapy, or patients who underwent salvage therapy for recurrence after prostatectomy. Answer is it looks pretty good. The purpose is virtually identical to these biomarkers, to the genomic biomarkers. The potential advantage of the AI approach is, rather than getting the tissue from the pathology lab and getting a little punch out of the tissue or sending the block, ultimately when some labs, including ours, are digitizing all or most of the pathology that comes through, then it just becomes a purely digital transaction. And that we're not there yet, but that's kind of the promise of AI, is that instead of sending all this stuff through snail mail, that the whole thing is you upload and then probably pretty quickly could get the result. And that's pretty amazing.
Yeah, I think so. The future is bright. Listen, I've said before many times, if there's a good time, no one wants cancer. I get it. If there's a good time to have prostate cancer, the time is now. Between all the testing, everything we know about PSA, everything we know about the MRI, and just technology, PSMA PET scans, we could just learn so much. Honestly, I'm a non-surgeon. Man, what you guys do, I'm in awe. I really am. Maybe by the time you guys do your 3000th, you're like, okay, of course this is what we do. No. I'm looking at it as an outsider, and I've been looking at it as an outsider for 20 years. I was like, you guys, it's amazing. I don't remember the last time I've seen a serious complication. Again, homogenous environment, NYU, or even patients from, anywhere, any of the institutions in New York, Michigan, Hopkins. So those are the patients that I tend to see. So that's that. UCLA, right? So I get to see the people that go to these high volume surgeons.
Patients do really well.
I don't remember the last time I've seen somebody who has like serious urinary incontinence.
And the surgery has gotten so much better over the last 10 to 15 years,
Yeah.
just incredibly so. Yeah,
Yeah.
we forget where we came from.
Exactly. Even I remember, because there was just way more. And of course, let me go to Dr. Espinoza to help me with his urinary incontinence after surgery. I'm like, man, I don't know. I'm talking to physical therapists. I'm talking to all kinds of people, and I just don't see it. I don't see it as much. So yeah, it's come a long way. I tell that to patients all the time that are on the fence. Of course, no one wants a biopsy. No one wants surgery. Get it. Got it. But I tell them, I'll tell you, and that it's pretty remarkable. And almost everyone that comes with some apprehension after they do it, they say, "Oh, this is not too bad. I would have done this. I would have done this before." Yeah. So remarkable. Speaking of surgery, but no, I have another question. Actually, I think I would love to have your input. Is there ever a time in your practice, Todd, that you have a Gleason 7 4+3 that you would say, I'll do genetic testing, if that comes up favorable, maybe you are a candidate for active surveillance? Are we there yet?
I am mostly not there yet. I think it's plausible. At this point, I do, to be clear, have some patients in that scenario who are on surveillance, but it's really driven by shared decision making and strong patient preferences. For patients who, maybe their life expectancy is less than 10 years, well, that's yes, we're watching them, but that's really more of watchful waiting. But the question of if there's a healthy 60-year-old gentleman with Gleason 4+3 cancer, am I putting surveillance on the table? No, at this point, I'm not. But I'm open to it. If if we're using Artera AI a little bit more and have more data, or Decipher or Prolaris or GPS more and have more data, that boy, when those tests come back low risk, and we're really confident that they behave more like grade group 1, then I think it would be appropriate, and I think it's very plausible we could get there in the next 5 to 10 years.
Yeah, I'm curious. I'm hesitant when they are asking me to help them navigate, but in some cases, like you said, they're saying, "Look, I'm not going to run away," because that's what I'm really afraid of. People who say, "Look, Dr. So-and-so said I'm a candidate for active surveillance. I'm just not going to get a PSA in years. I'm going to kind of run away." That situation I'm afraid of. But if they're diligent and sometimes, as you know, they need follow-up biopsies, and they're diligent with it, then I think that we'll see what happens in the future, so that we can make a more scientific and objective decision with these 4+3s patients. All right, so now they've been treated. Now, so they removed their prostate, or they've been treated. So if they do focal or radiation, we can't get any genomics from that, right? Am I missing something here?
Well, just not after treatment. No, we can use the biopsy specimen.
Right. So yeah, we could use the biopsy. That's Prolaris, Decipher, GPS core.
Yep.
Do you use the negative biopsy MDX Health one at all?
No, Confirm MDX. We don't. It's a cool test, a really cool concept. The science is awesome behind it. I love the science. The idea that there's a whole field effect of cancer, that even histologically normal appearing tissue next to cancer is actually biologically abnormal, and in this case there's methylation patterns that you can pick up. So the science is super interesting, but pragmatically it's not something that I use.
It just muddy the waters a little bit, right? It's like you're in active surveillance, but this Confirm MDX is not confirming that you should be on active surveillance necessarily.
Well, it's really for the negative biopsy, right? They're like, so it has.
I'm sorry. Correct. Yeah.
So you've got the elevated PSA.
Yeah.
And you got the right. What are you like? Is it going to drive a repeat biopsy? Oof. And are you just going to find grade group 1 cancer if you go back? So MRI. I think
that's what I meant to say. Yeah.
As that test has been developed over the last 10, 15 years, MRI has also taken off and become incredibly good for prostate cancer. And I think that test was the right test, maybe at the wrong time.
Right. All right. So now post treatment, the only time where we can do a genomics test is if they had their prostate removed, and now that specimen can be sent somewhere to be observed.
Yeah. Yeah. And so the test that is, I think, most commonly placed in that space is Decipher post-op. Prolaris can also be ordered. And here the concept, I think, originally was that we could use Decipher to inform adjuvant therapy decisions in select patients who underwent prostatectomy who are at high risk of recurrence. Ultimately, because of several trials, radicals, raves, the Jatug trial, so 3 trials that really called into question the benefit of adjuvant radiation over waiting for PSA to come up, in those patients, figuring out which patients actually had a recurrence, and then using salvage therapy. And because of those trials did not show really a benefit that we can tell so far to adjuvant therapy, using Decipher in that setting maybe doesn't look as promising. We actually ran a trial called G-Minor, Genomics in Michigan Impacting Observation or Radiation, specifically looking at this question, randomizing eligible patients, randomizing patients who might undergo adjuvant radiation to get Decipher or to not get Decipher. Those results we've presented a little bit. More data is coming over the next couple of years. So far, it looks like the Decipher test impacts some decisions in that space. Does it lead to improved oncologic outcomes? That's to be determined. So we'll see. Right now, how's Decipher being positioned now in the kind of the era where we're not really using much of any adjuvant therapy? I think it's going to be used to inform use of androgen deprivation therapy. So length of treatment, who needs ADT when they get salvage radiation and who doesn't. And so we know that there's really strong data that it can be used to help inform those decisions. And then we talked earlier about Artera AI in that space. It looks really promising again in this space to help make those decisions around ADT use or non-use or length of time of ADT for those patients who have undergone prostatectomy, now have a biochemical recurrence and need additional treatment.
Yeah, quality of life issues with ADT that could be prevented if you don't need it, all these wonderful things.
Yeah.
I think that's great. So so it could help us figure out if they need adjuvant therapy. And for the listener, that means therapy immediately after surgery, more or less, right?
Yep.
Am I getting that right?
Yeah, exactly. Therapy in the absence of
salvage,
recurrence.
let's wait until, versus compared to salvage, which is, we'll wait till something happens, PSA rise to a certain point.
And just to plug real quick, I get to plug this. The AUA / Astro / SUO, Society of Urologic Oncology, AUA, of course, American Urological Association, Astro is the Radiation Oncology Society. Altogether, we just put out a really, after 2+ year effort, new guidelines for salvage therapy for patients who undergone initial treatment, whether it's surgery or radiation or focal therapy, and then have a PSA recurrence. And there are brand new guidelines and really never been specific guidelines just for salvage therapy from these 3 organizations. So those just came out last month. And I'll be talking about that at the AUA.
And your group is responsible for that.
Well, I chaired the guideline committee, but it was a multi-D panel from all over the country, folks, radiation oncologists, medical oncologists, nuclear med expert. We had a big team, methodologists. So really a lot of work to put out new guidelines in that space.
Oh, I appreciate the plug.
Yeah.
By the way, you guys come up with the best acronyms I've ever seen. I love music.
It's good.
I love a G minor. I mean, you guys come up with. I mean, who is that? You or is that you hire people?
I did G minor. The music acronym either came from David Miller or Jim Monty, who started it. But look, if you're going to start a trial in music, you better make it work.
Oh man,
yeah,
beautiful. That grabs attention right away.
Yeah.
Tell us a little bit about music. What is it, and what is it trying to accomplish?
Awesome. Love talking about music. So this is a incredibly unique quality improvement collaborative run throughout the state of Michigan, housed at University of Michigan, but it includes almost every single urology practice in the state. So something like 95% of the urology practices and over 95% of patients at these practices are included. And so like 95% of prostate cancer patients in the state of Michigan are included in music. And it's funded by Blue Cross and Blue Shield of Michigan to the tune of many, many millions of dollars invested in it. But it's not like it's just restricted to patients who are covered by Blue Cross Blue Shield of Michigan. So it really covers care throughout the state. An initial focus on prostate cancer, now additional focuses on kidney stones and on renal masses and kidney cancer. And what happens in music is, so data is tracked, patient data is tracked, entered by abstractors at each site to a central registry. And so it's not using, at this point, any like automatic natural language processing or anything like that. So it's by hand data that's curated by hand into the central registry. And then every 3 to 4 months, so I think every 4 months, urologists throughout the state get together, whether it's near Ann Arbor or Detroit or Lansing or in Grand Rapids, and meet and decide what are the key issues to tackle, and then look at the data for all the quality initiatives that exist. And so, for example, an initiative to work to improve, increase the rates of active surveillance for low-risk prostate cancer in the state led to Michigan having by far the highest rates of active surveillance for low-risk prostate cancer in the country. Currently, about 90% of grade group 1 cancers, patients with grade group 1 cancer in the state, are followed initially by active surveillance, and the national average is somewhere around 50, maybe 60% at most now. So much, much, much higher. And another initiative was to aim to reduce rates of sepsis related to prostate biopsy with a kind of baseline rate around 2%. And so using several different approaches, including transperineal biopsy, which wasn't required, culture-directed, rectal swab-directed antibiotics, or just a broader antibiotic protocol, and also using formalin to clean the needle between biopsies, led to a drop to, I think, somewhere around 0.5%. So which you think, well, that's only 2% to 0.5%. But when you think about the scale of biopsies, it's a massive impact. And then Blue Cross Blue Shield comes back and says, this is incredible and the best thing ever. And you're improving health and obviously saving them a lot of money from the downstream consequences. So it really is a unique situation of a win-win-win.
Absolutely. How many patients are registered now?
I don't know the number, but tens and tens of thousands.
And is it continuous? They
keep going. Started in 2012 and continuous.
Brilliant.
It's amazing. Brilliant. Yeah, it's had a huge impact on care throughout the state, and the principles of not using it for practices to compete with each other that was the premise of the whole thing. Can you imagine trying to get all these different practices? I'm sure you can only imagine in New York trying to do this, but really to get practices to trust each other, share their data, and understand that nobody's going to say, on their billboard, well, our sepsis rate is 0.3% and theirs is 0.8%, but just use it to improve the quality of care throughout the state. And it has done that in spades.
Do you think, look, I've had several people on the podcast that reference the music trial. Do you think that several elements of the music trial, do you think it should be having a nationwide impact? Would you know?
I think it's difficult to measure. I mean, many people have early on said, boy, this is what a great model. And they've gone in their states and said, well, can we get our dominant carrier or carriers to support this? And there aren't many who have been successful at that. And Pennsylvania has the Pennsylvania Urologic something collaborative PERC, which is smaller, but it is doing some of the same work and uses the same registry, kind of the same backbone as music. But I think part of the reason it's worked here is that Blue Cross Blue Shield of Michigan is really a dominant carrier in the state, and so they have more of an incentive. I hope that what's being published, the work that we're doing here, does move the needle elsewhere. I think when people look at our publications that show a 90% active surveillance rate for low-risk prostate cancer in the state, hopefully they say, well, boy, maybe we should look at that, and maybe we can feel a little more confident putting our low-risk patients on active surveillance.
Do they keep adding on different outcomes as the trial goes on?
Yeah, I mean, and it really, it's so at its core, it's not even a trial. It's a quality improvement
Yeah. Yeah.
initiative, and
Yeah.
like the data is collected, the data elements can evolve over time, and they do evolve over time, but patients continue to be tracked, and so patients continue to be added to the registry. But patients who were entered in 2013 are largely still in the registry, so we continue to learn and continue to develop new initiatives. For example, there's a new one that looks like it's gaining some real traction around use of ADT and intensification of initial hormonal therapy in the metastatic hormone sensitive prostate cancer space, which music hasn't really put a lot of attention in. But of course, there are many urologists in the state who treat advanced prostate cancer. And so there's a lot of interest in improving the care for these patients with the help of music. And I know it's possible and it will happen.
I would love to. I would love, personally, if they added on some lifestyle components. So if they did A, B, and C, and they were X compliant versus Y compliant, we see these outcomes. Something I'm probably going to do somehow, probably within the next year. But you can use the infrastructure that music and those that are running it already have, right?
Yeah, for sure.
Todd, again, thank you for being on. Final words, and where can people get in touch with you?
Thanks. I mean, this is great. Like another time, I'd love to just pick your brain. I've gone down the rabbit hole of health and fitness, and even just did a VO2 max test the other day. So I'm like really I'm learning.
Okay,
I'm in deep. I did that. I did.
We have to do a grip
strength. I know these are the predictors, but I mean, I would just say that I'm learning a lot from your newsletters and your other podcasts, and it really is cool to get to know you. For folks who want to get in touch with me, so again, I'm at the University of Michigan. I'm chief of urologic oncology here. We have tons of research, clinical trials that people can, we'd love to have people participate in if interested. Of course, see patients with prostate cancer, but also kidney cancer and bladder cancer. And again, thank you so much for giving me the chance to be here.
My pleasure, Todd. Thank you so much. Thank you for listening, everyone. Look, this was loaded with good information on genomic testing and the different phases of prostate cancer. So I hope it was helpful for you, and I'll see you next time. Much love. All the best. Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in a world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.